Hi, everyone. Good morning. This is Amie Jasper, Residential DPT, St. Augustine campus. And my poster is on validity and reliability of virtually obtained functional outcomes in older adults, a pilot study. Telehealth, a form of digital health, is the utilization of electronic data and telecommunication technologies to provide remote healthcare services. The pandemic precipitated the rapid adaptation of telehealth in the United States. Common functional outcomes, um, sorry, used in the clinic to assess patient performance, such as 30-second chair stand test and time up and go, were found to be valid and reliable in the older adults. However, these studies were conducted in the hospital and laboratory with optimal device and internet connectivity. These factors may be more variable when conducting a telehealth visit in the patient's home. Following IRB approval and obtaining informed consent, participants were asked to participate in the study if they met the following inclusion criteria. They should be community-dwelling older adults aged 60 and older, receiving physical therapy in the home health setting, able to perform sit-to-stand and ambulation 10 feet without physical assistance, able to follow instructions in English, and had no weight-bearing restrictions in bilateral lower extremities. They were excluded if they had low vision or complete vision loss or complete hearing loss, because these are the requirements to perform the functional outcome measure safely and participate in telehealth. They should have the vision, the hearing, and be able to perform the functional outcomes safely. There were 3 raters in our study. Rater 1 was the in-person rater. Rater 2 was the live synchronous virtual rater. And rater 3 was the asynchronous virtual rater who scored the recording. Rater 3 was not present during the assessment. Raters were blinded from the other raters' scores. Face-to-face and teleassessment of TUG, 30-second chair stand test, and 2-minute step test were done simultaneously by the face-to-face and remote or virtual rater in the patient's own environment. The telehealth assessment was conducted using the Zoom for Telehealth platform. The intra-class correlation coefficient was utilized to establish inter-rater reliability, and then the concurrent validity was assessed using bland Altman 95% limits of agreement. 6 participants gave their informed consent and were included in the study. Mean age was 65, range was 60 to 71 years. There were 5 females, 1 male, and you can see the characteristics of the participants on table 1. 5 participants were referred with an orthopedic issue and 1 with cardiac issue. They had caregiver present throughout the assessment, and no adverse event was reported. Our preliminary findings showed strong and significant correlation between face-to-face and virtually obtained TUG, 30-second chair stand test, and 2-minute step test. The 30-second chair stand test was found to have a perfect agreement because of the fact that it is simple and easy to administer. 5 out of the 6 mean differences of the TUG and the 2-minute step test were within the 95% limits of agreement. The mean difference for TUG is within what we call clinical acceptable range, which is 5 seconds. The LOA for 2-minute step test has a wide range. It was challenging for a virtual rater to observe for the 2-minute step test if the right knee was reaching the mark on the wall from a lateral view. It is also possible that the duration of the test can compound the errors in measurement contributed by the quality of the image and speed of connections. There are a couple of clinical considerations when administering telehealth. The patients should have private high-speed internet connection. They should be comfortable with technology, they should have physical, cognitive, and communication abilities to perform the test safely and participate in video conference. The presence of a caregiver can assist with setup and supervision of the functional assessment. Moreover, the therapist should be able to communicate the instructions effectively on how to set up the environment and equipment to optimize the administration of the test. When it comes to virtual assessment, it may be easier to administer the test on patients with prior experience in physical therapy or with the selected functional outcome measures. Having these said, a hybrid of telehealth and in-person may be a more viable option. The strength of our study is having active patients in the caseload. Of course, our pilot study has several weaknesses, such as the presence of an in-person rater could have given added confidence to the patient. The in-person rater also provided the video conferencing device and set up the environment. Lastly, of course, is our sample size was small. In conclusion, the validity a virtually obtained tag, 30-second chair stand test, and 2-minute step test is substantially equivalent to face-to-face assessments. This study should be replicated with a larger sample size, which is where we are right now. We are on the data collection of the full study. Our pilot study was presented at CSM 2022 as a platform and will be published in the November issue of the Topics in Geriatric Rehabilitation Journal this year. Thank you.
Thank you so much, Amie. And for our final 2 5-minute presentations, we have back-to-back by Margaret Wazinski